So many important points that you just brought up. One that I just wanted to reiterate was that lifetime dose limit.
For the rest of this patient's life, they or the family will need to remember and be able to communicate a history of bleomycin treatment whenever anesthesia with high O2 concentration may be required for a future surgery. And that can be a challenge for our patients, as sometimes they don't even remember the names of the drugs that they received in the past.
You're listening to the Oncology Nursing Podcast, where ONS Voices Talk Cancer, a resource from the Oncology Nursing Society. Through conversations with subject matter experts, we examine the important issues in oncology nursing, from new treatments to patient-centered research to advancements in clinical practice. Join us as we hear from nurses in all facets of oncology care, from bench to bedside and everywhere in between. Welcome to the Oncology Nursing Podcast. Hello, and welcome to the Oncology Nursing Podcast. I'm your host, Stephanie Jardine, Oncology Clinical Specialist at ONS. And today we are joined by ONS member Rae Norrod, Manager of the Oncology Service Line at Kettering Health Network in Kettering, Ohio, and member of the West Central Ohio ONS chapter, to discuss the administration of bleomycin chemotherapy and what oncology nurses need to know. This episode is part of an ongoing series about outpatient oncology drug infusion. The others are linked in the episode notes. Thanks for joining me today, Rae.
Oh, thank you for having me, Stephanie.
So to start us off, what class of drugs is bleomycin considered to be in, and what is its mechanism of action?
Well, bleomycin is an anti-tumor antibiotic. This group of drugs is cell cycle nonspecific, meaning they work all the time in every phase of the cell cycle, including in G0. So it is best when we give these drugs in cycles with time in between for normal cells to heal and repair. Its action is thought to bind with DNA and inhibit DNA synthesis. Some sources say it may also inhibit RNA and protein synthesis, but to a lesser degree. In general, the greater the dose we give, the greater the cell kill.
Well, thank you. This is definitely one of those medications that has been around for a long time. And like you said, because it works in every cycle of the cell growth, it definitely can affect all along that continuum. So what cancer diagnosis is bleomycin used to treat? And in what healthcare setting do you usually see it given in?
Well, bleomycin can be used in a variety of cancer types, including some squamous cell cancers of the head and neck, cervix, vulva, penis. But typically we are seeing it in testicular cancers, in the BEP regimen, which is bleomycin, etoposide, and platinum, such as cisplatin, and in Hodgkin's lymphomas in the ABVD regimen, which is adriamycin, bleomycin, vinblastine, and dacarbazine. It could also be used interpleurally for malignant pleural effusions in certain cases. Typically, bleomycin these days is administered as an outpatient or ambulatory basis, but we still do see it sometimes in the inpatient setting, especially if the patient is newly diagnosed or it has been hospitalized due to their condition.
So one of the places that is a great resource for ONS members are our communities. There's lots of discussion that happens there, and nurses go there to ask questions that they have. And in our last episode, we talked about some of the questions that came up about certain treatments. And so for this episode, we also have a question that came up about bleomycin. And a member in the community was asking about administering this drug, either IV push or through a bag. How is it most commonly administered, and what do nurses need to keep in mind for each of these methods?
Well, I appreciate your comment about ONS communities. I find that the questions that other nurses often ask me to look up those answers and find out too. Now, bleomycin is given IV. There have been cases and reports, as well as manufacturers' literature, that say IV push or bag are both just fine. But the key points here would be the rate of infusion. Most commonly, we see bleomycin mixed in 50 to 100 mLs of normal saline and given over about 15 minutes or perhaps a little longer than 15 minutes. When it is given IV push, the push rate should not exceed more than 1 unit per minute. We know that bolusing or rapidly infusing bleomycin has been reported to increase the risk of certain side effects. So most commonly, we do see it mixed in a mini bag with about 50 to 100 mLs and given over 15 minutes or longer.
That's what I remember, was these little bags coming up to be given, again, alongside, that the big bag of etoposide and things like that. So thank you for that information. So as nurses are getting ready to start their patients on bleomycin, are there any considerations that they need to think about before a patient does start this treatment?
Sure. With any chemotherapy, the nurse would want to do a pre-treatment assessment before administering the chemotherapy, review the entire medical history, looking at specific risk factors that may go along with the drug, as well as a careful physical assessment. In the specific things for bleomycin, you'll want to focus on any pulmonary risk factors such as COPD, smoking history, check the CBC, and the renal function. We know that creatinine clearance is important, and any patient with a renal impairment may need to have the dose adjusted downward to reflect that. Most bleomycin is excreted through the renal route. Due to the risk of hypersensitivity reactions, check to see if there is a test dose recommended in this case or has emergency drugs available just in case. The emetogenicity potential is another thing to consider, to know whether you need pre-medications to manage nausea and vomiting. In this case, bleomycin has a minimal emetogenicity and may not require routine prophylaxis unless the patient has other risk factors. Because it's an IV drug, what is your route of IV access? Does the patient have a device such as a port or a PEC, or will they need a peripheral IV started? And certainly, as part of that pre-treatment assessment, we're also looking at patient education. Does the patient understand this medication? What have they already been taught? And are they ready? Have they signed an informed consent? Are also things to consider.
It's always good to, hear about what those considerations are for patients before they start treatment, because sometimes there are things that are very specific to treatment regimen that need to be looked at or evaluated prior to starting. So it's always a good review to know what those might be. You mentioned briefly you're evaluating your patient for the pulmonary issues, and bleomycin is associated with pulmonary toxicity. So how can clinicians prevent and manage this adverse event?
Yeah, boy, that is a great question. I know in general, bleomycin has about a 10% risk of interstitial pneumonitis. In some patients, this may progress to pulmonary fibrosis and challenges with hypoxia. This is thought to be due to free radical formation. Bleomycin tends to concentrate in the lungs. Some tissues in our bodies have an enzyme in them, a bleomycin hydrolase, that can activate bleomycin at the cellular level, and therefore some tissues in our body do not have a risk of toxicity. But because the lungs don't have this enzyme, those cells or tissues cannot break down bleomycin easily, and that's one of the mechanisms that allows this toxicity to occur. So when we administer bleomycin, it's important to get a baseline pulmonary function test, including a DLCO, which is the diffusing capacity of the lungs for carbon monoxide. This reflects the extent to which oxygen can pass from air sacs of the lungs into the blood. So, if patients already have a compromise or challenge with their DLCO, they may not be great candidates for bleomycin, or maybe we would need to more carefully monitor their pulmonary status. In general, the pulmonary function tests are monitored or repeated about once per cycle. Certainly, this is up to the provider and the patient's other risk factors. If they ever notice a decrease in function of about 30 to 35%, permanent discontinuation of bleomycin may be considered. Things that might complicate pulmonary risk or add to pulmonary risk include kidney issues, and that's one of the reasons why monitoring creatinine clearance and renal function is so important. If the kidneys are not as capable of processing or eliminating bleomycin, that can increase the risk of the pulmonary toxicities. Other things like older age have also been associated with a greater risk, as well as chest radiation, pre-existing pulmonary disease, and exposure to high O2 concentrations. So there is a lifetime limit to how much bleomycin may be administered. Most sources say 400 units per lifetime is the lifetime limit. Certainly, if the patient has complicating factors, that lifetime limit may need to be lowered to help mitigate that risk. This also means that for the rest of this patient's life, they or the family will need to remember and be able to communicate a history of bleomycin treatment whenever anesthesia with high O2 concentration may be required for a future surgery. And that can be a challenge for our patients, as sometimes they don't even remember the names of the drugs that they received in the past. During bleomycin treatment, this also means we want to check the patient at least at each cycle and see if they've had any challenges with shortness of breath, particularly dyspnea on exertion that is not typical for them, a cough, and listening for crackles. Inspiratory crackles are usually considered a hallmark sign of the beginning of this pneumonitis. The pneumonitis may occur rapidly within minutes to months of beginning to receive bleomycin, and that's usually considered reversible. However, because there's a lifetime risk, this could end up being a late or long-term side effect. It may not even appear until months or years after bleomycin therapy. In that case, when it occurs late, after all the bleomycin's already been given, typically the pulmonary toxicity becomes irreversible and may present challenges to quality of life in the future.
Thank you for that. So many important points that you just brought up. One that I just wanted to reiterate was that lifetime dose limit. And just like you were saying, how important it's going to be for patients and or family members to remember that with, folks being so transient nowadays and maybe even switching physicians or moving out of state and things like that. It's so important to remember and to make sure that the patients have that information so that they can pass it along. Or like you mentioned, if they're having surgery that could be for something completely unrelated to their cancer diagnosis, but just due to anesthesia, how important it is to know that and make sure that you alert, that anesthesia team about that.
Absolutely.
So that's, a pretty significant toxicity that occurs with or can occur with bleomycin. Are there any additional adverse events that nurses would need to be aware of?
One of the other things that some patients with bleomycin do experience is fever and chills for about 24 hours right after administration. So because of this, many times the pre-medications will include acetaminophen and an antihistamine. The patient may receive instructions to repeat acetaminophen every 4 to 6 hours for the first day or so to manage that fever. One of the other adverse effects or side effects that some patients experience are some dermatologic or skin-related reactions. Because the skin also lacks that enzyme, bleomycin dihydroxase, it cannot inactivate bleomycin like other healthy tissues, and you may have some toxic buildup in the skin. This might just mean some redness or rash or even some itching. In extreme cases, patients have noticed things that lead to a Stevens-Johnson's syndrome or hand-foot syndrome, where they have redness of the palms of the hands and soles of the feet that may be tender and maybe even itchy, and that can lead to challenges with quality of life. A few patients have even had nail changes, such as a loosening of the nail from the nail bed or ridging along the nails. And some have also reported hyperpigmentation or a darkening of the skin, the teeth, and the fingernails as a result of a buildup and the inability of the dermatologic or skin tissues to metabolize bleomycin.
So now I want to get back to another comment that came from the ONS communities. There was a discussion about test dose for bleomycin. Can you talk about what the best practice is for that?
Sure. And I know this is one that comes up periodically. Hypersensitivity infusion reactions have been noted in about 1% of lymphoma patients receiving bleomycin. Usually it would be the first or second dose when this would occur in patients who still, have lots of lymphoma disease present. This is thought to be due to the nature of the lymphoma cells and how they work with our immune systems. Symptoms of hypersensitivity infusion reactions could be hypotension, fever, chills, or maybe wheezing. The package insert recommends administering test dose of 1 to 2 units IV over about 15 minutes for lymphoma patients prior to those first 2 doses, and then monitoring the patient for an hour beyond the test dose to see if they have any symptoms of hypersensitivity. However, literature is suggesting that these test doses may not accurately predict reaction, and so many institutional policies and individual physicians are electing to not utilize test doses. So please check your policies and procedures to see if it is required with your institution or not. Those test doses may not be accurate in predicting who will have a hypersensitivity reaction.
That's really good to know and understand, and especially what you just mentioned at the end, that even if you do a test dose, you might not be able to predict that somebody would have a reaction. So we've talked about, the actual how it works and, some of the side effect management and things like that. Are there any patient populations that bleomycin should be avoided being used in?
Yeah, as we were just talking about hypersensitivity, patients who have had one of those hypersensitivity or other reactions to bleomycin may not be able to receive it in the future due to risk of perhaps a stronger reaction on a subsequent dose. There are some cautions with patients who may not be able to receive bleomycin or might need a dose reduction, such as patients with hepatic impairment. If their liver is not functioning normally, it may require a dose reduction. Also, patients that have challenges with their pulmonary function pre-existing may require a dose reduction or may not be able to receive bleomycin safely.
So like I mentioned, we've talked about a lot of different things. And, when we were talking about the dose limiting toxicities or the dose limitation too on bleomycin, lifetime dose limitation, that's something that we definitely need to educate our patients about. But what patient education should nurses be providing to patients before they start?
Typically, I advocate, and some of the national guidelines would advocate, that the chemotherapy education for all patients receiving drugs like this typically includes giving the patient a drug information sheet for each specific chemo or other anti-cancer drug that they're going to receive, and reviewing what are the anticipated or common side effects for each of those drugs. While we know each patient may react differently, some of these side effects that are specific to bleomycin include the risk of hypersensitivity reactions. So, especially for those lymphoma patients, explaining to them why they might be required to receive a test dose, why they might be receiving certain pre-medications, and how they're going to be monitored. And then what do we want them to report? The risk of fever and chills is another one. Because bleomycin often causes fever and chills in that first 24 hours, again, talking to the patient about what to expect. And if it is recommended that they take more acetaminophen after they get home to help manage that, what is the correct dose? Do they want it every 4 hours, every 6 hours? And then at what point would they need to notify their provider, their oncologist, if they're unable to manage that at home? Other things patients are often concerned about with chemotherapy is, will this drug make me feel sick? And will I have nausea and vomiting? In fact, nausea and vomiting is probably the most feared side effect. In this case, we might be able to provide some reassurance that bleomycin isn't particularly sickening and the nausea and vomiting potential is relatively low. So unless they're on other agents that do have a higher emetogenicity potential, the patient may not feel particularly sick or might not even need antiemetic therapy. Stomatitis is another anticipated side effect. So teaching them about oral care and how to keep their oral cavity clean and moisturized, and what symptoms to report, such as redness, tenderness, or other issues, to their provider. And then bleomycin may have a dose schedule that's a little different or maybe not as straightforward. In some of the regimens, bleomycin might be administered on multiple days each cycle. So, for example, on day 1, day 8, and day 15, or maybe only on day 1 and on day 15. This can be confusing to nurses as well as to patients. So providing them a written schedule that shows what is their cycle. Is it a 21-day cycle? Is it a 28-day cycle? And then what happens, or what days are they scheduled to receive certain drugs, including what are their upcoming appointments for labs, infusion, or to see the physician, can be really helpful so that they can keep it straight on their calendars as well.
In a time now where so much is done digitally and, everybody keeps their appointments and everything on their phone, I still feel like those printed out calendars with the specific cycles and the days that you're going to be receiving things. Also, just even to be able to visually show a patient that, this is the day that you're going to receive this treatment, but this is the day when you might not feel the best, and, be able to actually see, okay, and prepare for those patients. I get my treatment on Tuesday, but Friday is the day I'm going to have to really kind of be aware that I might not be feeling the best. I might be really tired. This is the day when my white counts are going to be the lowest. I really feel like those are still so important, and that being able to see that whole plan visually is a great education tool for patients and family members to be able to understand, this whole journey that they're on.
Oh, that's so true, Stephanie. Like you said, providing time frames for them can be so helpful, because they often have misconceptions about, will I be sick the entire time I'm on chemo? Or am I going to have low white blood cell counts the entire time I'm on chemo? And explaining things like nadir and even putting them on their calendar can be a very good visual prompt. No, these are the days that you typically experience different things.
And I think for their care providers, it's also such a helpful tool to, have them be able to understand it, for their, loved one, or, the person that they're helping to care for. just to recognize, so that during that nadir time or when they're really not feeling great, they can look back and look at that calendar and go, okay, we know that this is only going to last for this amount of time, or this is expected in this time frame, and we just need to watch for infection or watch for fevers and certain things, and then they are going to start recovering again after that. I think that's so important, and such an important piece for us as nurses to really do diligence and be good at educating patients and family members that way. So, talking about the nurses and administering and educating patients, is there any additional training or education that oncology nurses need to administer bleomycin?
Yes. Oncology Nursing Society is our professional organization that publishes guidelines and position statements that guide our practice. The position statement about the education of the nurse who administers and cares for the individual receiving chemotherapy, targeted therapy, and immunotherapy supports that nurses need specialized education, preparation, and training to both administer and care for patients receiving drugs like bleomycin. And after nurses complete a didactic class that has all the required content, they further recommend that that nurse goes through a clinical practicum in which he or she can demonstrate that they have both the knowledge and the skills to administer these drugs safely and to monitor the patients who are receiving them. Some of the things about bleomycin we've discussed today that you really need to know: how this drug works, what are the anticipated side effects, and how would you manage and monitor patients who are at risk for those side effects. In addition, bleomycin is a NIOSH Group 1 hazardous drug, and because of that, it does require safe handling precautions per OSHA guidelines. NIOSH Group 1 hazardous drugs are cytotoxic or cell-killing, so they're hazardous to both males and females who are actively trying to conceive, in addition to women who are pregnant or may become pregnant, and women who are breastfeeding. So OSHA states that all personnel who come in contact with HDs need to receive safe handling education to protect themselves and to protect others, as well as the environment, from inadvertent or accidental exposures.
Thank you, Rae. This has been so informative, and you've given us some really great information and education on bleomycin and the administration of it. And as we're coming to the end of our podcast, there are a few questions that I ask on every episode, and I just want to kind of finish us out with those. First of all, what are common misconceptions about this treatment?
So I think the thing that comes to mind is how many questions there are about bleomycin and the risk of a hypersensitivity infusion reaction. So as we discussed earlier, I just wanted to bring out that the hypersensitivity is more common in a lymphoma patient versus someone receiving bleomycin for a different cancer like testicular cancer. So double check if your institution requires test dosing or does not require test dosing. And we should always be prepared, at least on the first and second doses, in case a patient may have one of those reactions.
Great. And then what is something about bleomycin that's not often discussed, but you wish people knew more about?
Well, I think, again, we touched on it a bit earlier about the pulmonary toxicity risk, but how challenging it is for our patients to remember the names of the drug they received. I know you can tell somebody in the moment and they'll say, well, yeah, I'm always going to remember that I got this chemo and how challenging it was to get this chemo. But to tell you the truth, when they come back 10 years from now, they probably cannot tell you the names of the drugs. They may not even remember if they had specific side effects. So because bleomycin has a lifetime risk for pulmonary toxicity, they at least need to be able to remember and communicate with an anesthesiologist prior to surgery that they've received this drug. Today, electronic medical records are helping us with this challenge because they can track cumulative lifetime dose and also communicate or set off a best practice alert for anesthesia that this patient has received bleomycin in the past. But depending on when your facility first implemented the EMR, and if your patient received bleomycin in a different facility or maybe even in a different state, this information may not be readily accessible to the patient or to any providers in the future. I know we used to have patients on paper charts, and not all of that information was inputted when we first implemented electronic medical records. So we may not have accurate dose history on some of our patients who are still receiving care from us. So providing written information to the patient and maybe to their primary care physician as well, such as a survivorship care plan or a treatment history that outlines the names of the drugs they received, and in this case, cumulative dose of their bleomycin, can be very helpful so that it's more readily accessible and so that more than one location or more than one provider readily has access to that information. As you mentioned earlier, Stephanie, patients travel, they move, they change doctors, they go to a different state. They may even just simply go across town to a hospital system that has a different EMR. So having a backup written document, as well as reiterating how important it is to remember bleomycin at every survivorship visit, can help prevent an accident or an unforeseen adverse event.
Thank you. You're right. We do have EMRs now that are extremely helpful. But as you mentioned, even just across town, those EMRs might be different and may not talk to each other. So how important it is to make sure patients know that and remember it for, years to come. And then finally, what are some additional resources for both patients and providers who want to learn more about bleomycin chemotherapy?
The ONS Chemotherapy and Immunotherapy Guidelines book is very helpful. There's drug information tables that include chemo drugs like bleomycin, and they're organized per category or classification. In this case, you may recall that we said bleomycin belongs to anti-tumor antibiotics, which work all the time in every cell cycle phase. That book also, besides the drug tables, includes a section on pulmonary toxicities, cutaneous toxicities, and other side effects that the patients may experience. ONS also has a clinical guide for anti-neoplastic therapy that has excellent sections on drug information and on various side effects. The package insert and manufacturer's recommendations are always very helpful, especially to pharmacists and physicians, as well as nurses who are trying to double check the dose, double check side effects, or even preparation instructions as they're getting ready to administer these drugs. Great web sources are available to both professionals and to patients, such as National Cancer Institute, chemocare.com, and published articles in peer-reviewed journals that talk about pulmonary toxicities or other chemotherapy side effects and what is the latest evidence-based practice. Certainly for our patients, I always encourage them, even though they might find references on websites, to always talk to their provider. They may also, depending on where they're receiving treatment, have access to pharmacists and to certified oncology nurses who can support them to get accurate answers to their questions and to provide the guidance that they need to take care of themselves at this time.
Thank you so much, Rae. Again, like I said, this has been so very informational and just such great content, especially for our newer oncology nurse listeners or who, tune in to find out more about treatments that their patients are receiving, or someone who just needs a refresher. It has just been a lot of great information. Do you have any final comments for us today?
Oh, Stephanie, I just thank you for this opportunity today to help give nurses, as you said, that great review, or to help our newer nurses as they're being introduced to drugs and common drug regimens. Safe practice is possible. It takes a team, though. So remember to always double check yourself when you're getting ready to administer these drugs, and work together as a team with your pharmacist, your prescribing medical oncologist, and others, not just for yourself, but also to assist your patient at this specific time of their cancer journey.
Thank you, Rae, for joining me today. I really appreciate it.
Thank you, Stephanie.
Thank you for listening to the Oncology Nursing Podcast. Tell us about your favorite part of this episode by leaving a review on iTunes or wherever you downloaded your podcast. For more resources and information about oncology nursing, visit us at ons.org or voice.ons.org. The ideas and opinions shared in this episode represent those of the guests and not necessarily ONS.